Squats.
Yeah.
Everybody loves squats. Do
No,
squats.
no. Nobody loves squats. Come on, Gil. Nobody loves
Let's
squats.
say squats are popular.
Okay.
Let's say the pendulum has swung towards squats. You're squatting down. You take your knees to 90, or you go all the way ass to the grass.
No,
What is the best form? What's the best knee?
It depends on what lift you're doing, right? There's some Olympic squats where you have to get all the way down.
Hello, welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is Dr. Byron Bus Tarbox. Welcome to the show, Bus.
Well, thank you. I appreciate you having me here.
What a pleasure it is to have you here. Bus is an orthopedic surgeon. He's a fellowship-trained sports medicine specialist, and he happens to be the team physician for the University of Missouri wrestling team.
Yeah, that's correct. It ranked 5th in the country at the end of this year. Yes.
Oh, that's fantastic. I know one of your colleagues was the orthopedic surgeon for the women's Olympic soccer team.
Yep.
When Pat Smith was doing my shoulder, his phone kept ringing. I remember a gymnast blew out a tendon, and a football guy hurt his this or blah, blah, blah. So you're in a very busy group of great orthopedic surgeons and sports medicine specialists, and it's a real pleasure to have you here today.
Well, thank you.
Today we're going to be talking about injuries of the knee. And, you know, in football, you hear, career-ending injuries. Or I think, correct me if I'm wrong, the number one injury that professional football players and other sports people fear is the dreaded knee injury.
Yeah, sure. I mean, when you're a high-level elite athlete trying to compete at that level, a torn ligament in the knee or a meniscal tear in the knee can slow you down even at that level of professional athletes. A 10th off of your 40 time or able to cut and react can mean, playing or not. So it's a big deal.
Yeah, it's an incredible joint. It bends.
Yes, it does.
This way.
It's a hinge joint, yes.
And it doesn't want to bend this way.
That's correct.
So vulnerable.
Yeah.
It has these, and we'll go into the anatomy in a little more detail, and it's got these ligaments that cross, Latin for cruciate.
That's correct.
To cross, that somehow I'll keep the knee stable and allow it to bend at the same time.
Yeah.
It's just amazing. Then you've got these, and correct me if I'm wrong, but you have these cushioning areas of cartilage, a meniscus, and these cartilage layers and these fluid layers. And then you have these tendons or ligaments around the knee that keep it stable. You've got a patella in front of it, this enormous quadricep tendon, patella that goes over it. So it's very strong, has to do a lot of things, yet is incredibly fragile if pushed in the wrong direction.
But it's necessary, right?
Right.
To locomote around. You bet.
Right. So everybody with two legs needs a good knee. So tell me, what are the most common knee injuries that you see in your practice?
I think I'm a sports medicine trained physician, so I don't do the total knee surgeries. I have my partners that do that. But I'll see anything from, the pediatric injuries. Sometimes you get some the growing pains that a young pediatric athlete would have, up to, as you nicely described in the opening here, the anatomy of the knee, from the articular cartilage, the meniscal cartilage, the ligaments that surround and protect the knee, on up to the muscular structures around the knee that help make the knee move. So.
Well, I guess let's go in order of age. So you said like a young person, maybe in the early teens, or did you say pediatric? Do you see injuries in children?
Yeah, sure do. We see a lot of the younger injuries. If it's fell off a bike, or I was in a dance class and I overdid it. You see a bunch of young teenage athletes that can get hurt, can overdo it a little bit, and so a lot of times those younger injuries, although we can have those torn ligaments, like the ACL and those other structures in young kids that are 10 and under too. I mean, it's a horrible injury to have, but sometimes we need to address that if trampoline or
Oh, that's
motorcycle
right.
accidents. I've had, had a kid that crashes, was on his dad's, motocross cycle. His young kid
Right.
from Fulton, 13-year-old or so, crashed his dad's motorcycle, that the little motorbike, and tore up his knee, tore his meniscus, tore his ACL, and we had to come back to a couple stage surgery to fix him, and he's done well and moved on. So yeah.
Wow. So, as a child, do I assume that if a child has a knee injury, it's going to hurt?
Yeah, of course.
So, what types of pain or discomfort should alert, let's say, a parent to their child? Gee, might think my kid's got a knee injury.
I think kids in particular are pretty robust, and most kids bounce back. And I think when we see young kids that may have fallen on the playground, or fell roller skating or on the skateboard, and they can have injuries of the knee. Now, what we worry about is some of those younger ones, that they're truly a high mechanism injury.
What does that mean?
Well, if fall from a height, or running fast, and as we talked earlier about maybe some football type injuries where you get hit and the knee bends in the wrong direction. The kids can have those problems as well. Sometimes, though, in kids, and we can go through the anatomy a little bit, you can have not only the ligament injuries, you can have fractures that occur. Sometimes the bone may release before the ligament does, and so you can get injuries that are more like an ACL injury, but it's called a tibial spine fracture that we have to repair.
Oh, wow.
So yeah.
Well, let's start simple, boss. You've got a kid and knee is hurting. Is it going to swell a little bit? Is it going to, a particular motion going to hurt? What's going to alert, let's say, a parent that, gee, I should take my child? I mean, they may hear sports medicine, but you're going to be able to handle any knee injury pretty much. So when should they bring their kid to you, boss?
Well, as kind of talked about, I think kids are pretty resilient. So if a child is complaining excessively and not walking on a leg, and not walking because their knee hurts, and a parent can easily assess that. Put your hands on the knee. Is it warm to touch? Is it swollen? Compare it to the nice thing about the human body. In most cases, there's a comparative side on the other side.
Right, a control.
Does the injury side look like the non-injury side? And so that becomes pretty easy to do. Put your hands on it. If the knee doesn't want to move, it's a hinge joint. It moves back and forth. If the young pediatric patient doesn't want to move the knee, that's a problem. That needs to be evaluated. Swelling, warmth to touch. Then you worry about fevers and chills and other,
and limping maybe.
Limping for sure.
Right. So, okay, so that's fairly straightforward. And if the kid is being honest and it's not hurting, we could probably say it's probably not that bad. Right?
Yeah. And if the kid's walking around, a lot of those are self-limiting at the really young age, right? And then when we get up to, the older athlete or the older person who's now maybe in their teens, and now they're the speed at which they run or they do their activities is much faster than the younger ones. But then you get higher energy that in those injuries, right? So if a patient or a young athlete is playing on the football field at Rockbridge High School,
right,
and is running pretty fast and stops and turns or gets hit, we always think about in orthopedics the amount of energy that's going to go through that joint. It's an energy thing. Where is that energy going to be displaced? Where does it escape from? Does it cause a broken bone? Does it cause a rupture of the tendon or a rupture of the ligament?
Well, that sounds really bad. So maybe we can talk about the severity of injuries. What is a strain?
So a strain is when we talk about, and we can talk about the anatomy.
Yeah, please go right ahead. Go right ahead.
Sorry. So this is a knee model, and you can see the knee consists of three bones. It has the femur, which is the thigh bone that we talked about.
The femur up here is the femur.
Is the femur, yeah.
Okay.
And then the tibia, which is the shin bone.
Okay.
And then the small little bone on the outside, the fibula.
Right.
And that makes up the bony anatomy of the joint itself. Now there's a fourth small sesamoid bone called a patella.
The kneecap.
The kneecap, exactly.
Gotcha.
So that's the main bony anatomy. Now the inside you see in this model here, you see the orange structures here. These are ligaments. Well, I'm going to come back and answer your strength question, Gil. But,
Yeah, sure.
So ligaments, when any two bones come together, we call that a joint.
All right.
You have fingers in your joint, your neck, everything. When two bones come together, that's a joint. How do we stabilize that joint? A joint is stabilized by ligaments.
Okay.
Okay. One of the first questions you had in your high school anatomy class was, what's the difference between a ligament and a tendon?
An tendon, right.
And when I have young high schoolers in my office, when I get ready to evaluate them, I ask that question, and it's, well, what does that mean, right?
Right.
And a ligament stabilizes two bones.
Bone to bone.
The bone to bone. A tendon is how a muscle
It's muscle to bone.
attaches to the bone. That's the conduit in which the muscle then attaches to the bone
Gotcha.
through the tendon. So that's now we've given the first anatomy answer.
Good. So a strain. So what is a
So then
strain on one of these
A
structures?
strain then is an injury to the tendon.
To a tendon, not a ligament.
No.
A strain is an injury to the tendon. Gotcha.
A sprain is an injury to the ligament.
Now would this be like a small tear?
Well, it can be, or it can be just a stretch. When
Or
you
a stretch.
When you sprain your ankle, you get you sprain those ligaments in the ankle. A sprain of the knee can stretch those ligaments.
Okay, so maybe micro tears or some type of injuries. Okay.
Yes.
Is this okay?
And that's
so I've
a
learned
sprain.
something
So
already.
A strain is injury to the tendon. A sprain is injury to the ligament.
Gotcha. Now, then we get into actual tears.
Yeah.
Right? And any of these ligaments you can tear?
Yeah. So when we go through it, in the other structure that we mistalked here is inside between the thigh and the tibia is the meniscus. That's the cartilage. When you hear about athletes tearing the cartilage, they miss the game because they got a torn cartilage.
It's the meniscus.
It's the meniscus.
So it's kind of sandwiched in there. It's
and you
kind
can
of
see
cushion between
you
them.
see here that it's a cushion, and it's really. And the meniscus has a couple functions. One of which it's a shock absorber. It prevents, it helps with shock absorption of the knee.
Okay.
As well as it also provides some stability to the knee. So let's go back to the definition of a joint where two bones come together. The function of the ligaments stabilize the joint. Now there's four major ligaments in the knee.
Tell me.
There's the MCL, the medial collateral ligament, the one on the inside of the knee.
Inside of the knee.
The LCL, the one on the outside, the lateral collateral ligament.
Was that like kind of controversial whether it was there or not? Or if they always know?
It's always been there. There's some newer literature out about some other ligaments that they're now starting to see in the knee.
But the MCL, that one isn't that attached like in three places or something? Is that why it doesn't move as much?
It's attached in two mainly.
Okay.
On the medial femoral condyle, then down on the tibial, down below here.
But there's something about the MCL, right, that makes it more vulnerable.
It's got several layers, but it's just I think the anatomy of the knee that just the function and the way injuries occur.
Okay.
Now the cruciate ligaments stabilize, and so what a ligament. So the cruciate ligaments are the two in the middle, and you described that earlier.
And the cross.
Yeah, the cross cruciate. Yeah. So if I take a knee and I grab. If we can see this here. So here's the medial collateral ligament. If I take the foot, examine the knee, and I pull it out, you kind of see it stretch.
Right.
Okay. If I take the foot and I pull it in, you can see this side.
That side stretches.
Yeah. Now the cruciate ligaments, so the collateral ligaments side to side bend.
Right.
The cruciate ligaments prevent front to back.
So if you're going along and you hit a rock or a tree stump skiing,
something's gonna happen.
You stop, you plant your foot in basketball,
or we have athletes just recently took care of a Missouri athlete that came down on his knee and hit in a way in which drove the tibia backwards.
And it will tear the posterior.
Yeah, a lot of times we'll see that in high trauma, vehicular trauma. Sitting driving the car and hit the dashboard, head-on collision, and the knee hits the dashboard, the tibia gets driven back, and we tear the ligament to the back.
Tears the posterior cruciate.
Yeah. So
you can get injuries to all these things, and an actual tear of the ligament. Now, I assume you can have partial tears and complete tears.
For sure.
So how do you determine what to do with a partial tear?
Well, that's up to us to decide as we examine the patient. And as you know, there's a number of factors to decide how you treat someone based on their activity level, what they're trying to do. A partial tear, how unstable in this case, how unstable the knee is. But we can, when we put our hands on our patients and examine them, we can determine how unstable they are. Dr. Smith uses another device that he actually grades that based on a mechanical device on the amount of translation, how much the tibia slides forward in like in an ACL injury, how much this comes forward.
So you can quantify or put a number on that.
Yeah, that's correct.
Now we start talking about children and how we all know they can heal better.
Yes.
Will a child's ligament generally heal better if it's just torn partially?
It can. Yeah, and I mean, children always heal better than
Right.
adults.
Right. I'm just wondering,
But
if you're getting old
sometimes-
like me, if you get a partial tear, what's the chance that it's going to heal?
Well, it can. A lot of times that we can brace through. That depends again on the patient, what their expectation and their functionality is. How active they are. Are they out on Hawthorne playing pickleball on every night, and they're having trouble making those moves and doing those activities. Right. And so, can we treat them? The age in an ACL historically, through my 20 plus years and even back through my training, everyone said ACL need to be reconstructed in someone young. The oldest ACL I've done is someone who's 63 because they were unstable and they were functional. They wanted to play pickleball at Hawthorne.
Otherwise, they had good quads, good feet, good heart and lungs.
So let's go fix it.
It deserved fixing.
Yeah, and so I've had a patient sometimes, if you look on the website, there's a story on our website about one of my patients a long time ago that she showed up a long time ago and said that she had been seen by another orthopedic surgeon in the area.
Okay. Who
said that she was a 40-year-old female and her desire was to run an Ironman, right?
Swim, bike, run. Very far.
Exactly, right? And she was told by another orthopedic surgeon in the area that she was too old and 240 and too fat to have the case, right? Whatever.
Right.
And I said, no, you're not. Let's go. And so
I do that in the OR too, where people come to me for a second opinion, and frequently we can fix things other people don't feel comfortable working on.
And I think that's the art of and the practice of medicine, right?
Sure is.
Let's sit down and have that discussion. Is it going to be easier for her to get through than a 60-year-old? Probably not. We're going to have to work a little harder, but we can get you through it. I'm not. That doesn't scare me. Age doesn't scare me. We can get you through it. We just have to work harder. You have the same experience.
Sure.
So I ended up taking her to the operating room. I reconstructed her ACL.
Now, did you do that through little telescopes?
Yeah.
Like in the old days, maybe not so. You have to make some big, horrible Frankenstein scars.
And those patients stayed, in a cast for several weeks and ended up with a stiff knee and a bad outcome.
But you,
now,
with modern techniques and experience, can make little holes.
We do it through the scope.
Amazing repairs.
Scope about the size of my pen. I can look all around on a 4K monitor.
Right.
So we ultimately reconstructed this patient of mine, and she ultimately then went and ran her Ironman and completed it, and good for her, right?
Good. That's very gratifying, Buzz.
Yeah.
Fantastic. So maybe we should talk about more specific injuries that you see daily. And then tell me, what kind of injuries do you see and how do you treat them?
I think as we've kind of discussed the anatomy, the one that we didn't really talk about here is the patella, the kneecap. The kneecap can dislocate. So another one of those. So everything in this knee model can tear and can get broken, can get
out of alignment.
So this whole model here is something that we can all sit down and reconstruct.
So this kneecap can go over. Is there one side it goes to, or it can go either side?
It mainly dislocates, or it only dislocates laterally.
It goes to the side, outwards.
To the outward.
Outwards.
And that can happen.
And when that happens, right?
Yeah.
Can you just push it back in?
You can. If you get there quick enough, and usually with it really any dislocated joint, if we can get there quick enough, we can do it without sedation. We just get there and reduce it.
Just do it.
And the patient
bite
will
on
scream
this.
bloody murder, and then they go,
the relief.
And the relief.
I know shoulders are like that too, right? To
shoulder.
pop that sucker back in, right?
Yeah. the football player that's down on the sideline with a dislocated shoulder is screaming bloody murder until we get there and reduce it. And then it's like, oh, thank you.
Thank you.
Yeah. So anyway, let's go back to the knee.
Okay.
So everything in this can be damaged, right? So we can talk fractures. Everything
Sure.
in this can be damaged. Someone falls from a height, they can break the femoral side, the thigh side, can break the tibial side, the shin bone side.
So what happens if you break the bone at the joint? That must be horrible.
Yeah, sure is, right? Because
How can you fix that?
arthritis is, when you eat chicken wing or you trim your turkey on Thanksgiving,
Right.
you take off that leg and that beautiful white articular cartilage cap is absolutely gorgeous, right?
We surgeons notice this,
Right.
before we eat it.
That's what the knee runs on. In fact, Gil, the amount of, when we talk about friction, you remember the coefficient of friction back in your physics class.
Lubricity.
Yeah, what it
slipperiness.
takes. Yes. And the coefficient of friction in a joint is lower than anything we can make man-made.
It's amazingly low.
Yeah.
Incredibly well developed.
If this surface gets disrupted through fracture or through breakdown of the articular surface, that increases the friction. So when someone breaks this or has a fracture through the joint, that needs to be fixed. And we have our fracture guys do that, go into the joint, line up the joint, and then fix the bone back in there with implants to hold it in place.
Like a screw or a nail.
Yeah,
Okay,
exactly.
so you're gonna
Put it back
nail it or
together.
whatever they get, screw that together accurately so you get a smooth surface.
To get it as smooth as possible.
Okay.
Now, we see arthritis in the arthroscopy world because what happens in arthritis, we said, is the articular surface actually breaks down. It actually starts absorbing water, which then it softens, and then it starts getting a little shaggy. And so instead of a nice smooth surface, now you got kind of a shaggy surface.
Okay.
And that now becomes that grinding that as we get older, you walk up down the steps, you feel this.
So that's where the nice shiny cartilage has worn down.
Yes.
And you've got rough spots now.
Yeah.
But what can you do about that?
Well, we'll get there.
Yeah.
we can fix that. Now, you also can tear the cartilage. We talked about meniscus tears.
The meniscus, yeah. Now,
So
as a medical student, this is many, many years ago now, I remember them going in there and taking a biter. I don't know if it's called a rongeur or something. And they would just
a meniscal biter, a little different than a rongeur. Rongeur we use on bone.
Okay. They were taking bites and said, they're not going to miss it. And they would take a lot of this out.
Yeah.
But that wasn't necessarily a good idea,
Yeah.
was
So historically, someone comes in, 30 years ago, 40 years ago.
Okay.
If someone tore their cartilage in their knee, the meniscus, we would make an incision and pick the whole thing out.
Wow.
Because we thought that's what was the right thing to do. Well, then 20 years passed, and those young, now that happened when I was 18, and now I'm 38, and I have a completely degenerative knee, because now we know we need that in there. So
they've lost their shock absorber, more pressure on those exposed contact points, and it wears down.
Yeah. So now what we do is if that meniscus is torn, we can repair it. Obviously, it was created.
Repair it.
Yeah. Obviously, it was created and put there for a reason. So
how can you repair something with very little blood supply that doesn't heal well?
That's a good question. So we either can repair it or we trim it out, like you just described. But what we try to trim out is just the inner 2/3. The blood supply in a knee comes from the outside. So this C-shaped structure, all the blood supply actually comes from the outside.
Comes from outside in. Okay.
So if the tear is out here in this outer area where there's blood, we can
heal.
We can put suture across that and fix it, because then the blood
you can
is right
suture
there.
that.
Yeah.
Now, do you use a permanent suture?
Yeah, the suture is permanent. There's a couple different ways to do it. One, you can make an incision and pass that stitch and tie it down. Or we do what's called an all-inside, where we actually use a device that goes across the tear.
Okay.
Goes across the tear, and then it squeezes it down. So we need.
What's it like a twist tie or a pull tie or a staple or what are we looking at?
It's a self tying knot, and we can either tie the knot. We can tie the knot and slide the knot down to repair it, or it's a self tying knot. You just pull on it, tug on it a little bit, and it auto tightens.
I used one of those on an appendix yesterday.
Yeah, there you go. Yes.
Yeah. It tightens down.
Now, but
you leave that suture in there and it's smooth enough.
Yeah. It does.
And
in the body
to stay there.
If it is good blood supply, sometimes the body can encapsulate that
So it smooths out over time. Okay.
Yeah.
All right.
If it's in this area here, what we call the white zone, the inner 2/3 where there's no blood supply,
Okay.
sometimes we just trim that out. Now, as our technology has gotten better, we're seeing more and more meniscus being repaired through that area, that white zone. If someone is younger, if and you need blood supply, you need healing factors in there, and you hear
Right.
about different ways to do that. PRP, platelet-rich plasma injections.
So you can get some stem cells in there. There is a role for that?
For sure. And we have a higher incidence of the meniscus repair healing if we do an ACL surgery at the same time, because we're causing so much bleeding in the joint as we do the ACL reconstruction.
I'll be darned.
There's already blood in there to help heal that. So there's different factors that then help that repair to heal.
That's true in the uterus too. I won't go into it. It helps embryos implant.
Yeah,
Helps
exactly.
embryos implant.
Sure.
Believe it or not.
For sure.
When you tidy things up, there's other benefit.
Yeah.
So you can fix it. Now, how would one injure the meniscus? Once again, one of these where the knee's getting pulled in a bad way, or an accident, or
a lot of times that meniscus injury, and we see it in guys our age that bend down, and they're working on their car, changing the air, or doing something in the car, and as they get up from that squatted down position, and what they'll do is it'll get caught and it'll rip.
Oh, it's caught, bad angle, and then you tear it when you're moving it up.
And so we see that on the football field. We see, or on the wrestling mat, where the knee gets put in a difficult position. It gets twisted, and it's usually that twisted position then that causes this to tear. And the athlete or the guy working on his car, it's not just athletes that tear their meniscus.
Right.
Anyone can tear it. We all have them.
Right.
You'll feel a pop, have pain, and then typically swelling, because if it tears through that bloody area, it'll bleed and we'll get some swelling. Now, then what the patient will then know, or the person will know, that sometimes they'll be walking, their knee will lock up, or they'll bend down again to pick something up, and the knee locks, and a lot of times that's because now the meniscus may flip up. You can get tears like this.
I don't like that.
And
that's what that could be.
And then it's locked, or their knee will give way because when they're walking, that meniscus can move a little bit. It's torn. There's nerve fibers in there. You step on that nerve or that torn meniscus, it hurts, and your knee gives way.
And you just guard and go to the drop to the floor.
Yeah.
Now, how can you diagnose? Let's say you suspect.
Yeah.
Guy comes in, he stood up wrong. You suspect a torn meniscus or something. How can you diagnose that?
Well, by examination, the majority of the time we can tell. And what we do...
An experienced surgeon like you.
Yeah, with the great hands, right?
With the best hands.
No, what we do when we examine the knee is we can push on that joint line. So if that meniscus is torn, you kind of see where we've kind of drawn a tear in there. If that meniscus is torn and I push on it, so I can push on it through the skin, and I'm moving it back and forth, you're going to feel that pain, right?
So your exam is so focused, you can say,
I can push right on the joint line, and then that's just palpation of the joint line, and I can push all around to see is it sore here, is it sore there.
So an experienced orthopod like you can actually give you a very specific, likely location of the injury.
And like with any, then there's other tests. We use a test called a McMurray test, where we flex the knee up and we kind of twist it. And as we twist it, if that's torn and I'm catching it, sometimes you feel a pop. Patients are like, it hurts, don't do that. I think you got a meniscus tear. Confirmed then by an MRI.
That's what I was trying to get to. Now that the incredible experience is manifest, then you're going to confirm that, right?
Yeah.
So we get an MRI?
Yeah. We get MRI. We get x-rays and determine the bony anatomy of the joints.
So there might be a role for a plain old x-ray.
Yeah, for sure.
Different angles.
For sure.
And an MRI.
Yeah. So what an MRI does, it allows us to, and MRIs are amazing. They use these magnet things that I don't know. I've had
Yeah, when
them.
my shoulder was bad, I couldn't tell what it was, but I remember the radiologist said, "You've got a hot shoulder." It's like, well, because of this little thing here, this little thing here, and you guys can tell these things.
I don't know the physics behind an MRI. I know the magnet turns on, and then the electrons displace, and they give off a signal.
It flips the water one way, and then it unflips the other way.
Right?
And they listen in.
I don't know how they figure it. They're smart enough. But anyway,
they're smart.
Because as we know the anatomy, I know the anatomy. We can now look through the knee and understand all the process. So within an MRI, and I don't know if most of our patients, I usually take the MRI into the patient on my computer to review it with them, so they understand what they're looking at.
So you can see small things, a
you
millimeter,
can see
2 millimeters.
Our MRI of a knee is usually cut at about 3.5 or 4.5 millimeters.
Okay.
Every cut of that MRI is 3.5, 4.5 millimeters or so.
Okay, so you can see 2-3 millimeter injury. You can see.
Yeah. And so you
now
put
you know
it together,
where it is.
and then if you know the anatomy, and then you can apply the anatomy that you know, and then look at the MRI, the advanced imaging, and then make that determination. Look, here's your tear. And so I can say, just like you when you had your shoulder,
right?
I'm sure you're told you had a torn whatever.
They suspected,
and then here's why.
Right.
Here's why, because we know the anatomy, and here's what the injury looks like. And we know that. And that's why we can tell if the meniscus is torn. We can tell if the ligaments are torn. We can see fracture damage. We can see all that.
And this is why it's so important. I say this many times in many of these episodes, Bus. A physician extender can be wonderful for a sore throat or a cut or something minor, but something like this requires a highly experienced physician that's been doing this for years and years and can make very accurate, proper diagnosis.
I think we use physician extenders, APPs, in my daughter's one, and she can examine a knee, and she does a really good job, and she would, I think, defer.
Hey, Bus, I suspect blah blah blah, but then we need these highly trained specialists, Bus, for top-notch care, and I'm just going to continue lobbying and advocating for that every chance I get. So, what is bursitis?
Okay, so that's kind of all the intra-articular start. So if you put a bursa in the body, is where there's an area of high friction. Okay. You got a bursa on your elbow. If you and I sit here all night long and have this discussion, and we're rolling our elbows back and forth, we might get a little swelling in our elbow because that bursa.
Really?
Because there's an area of high friction, right? There's right there as the skin runs across the elbow, right? So if we're doing this a lot, we might do that. Or we get down on the knee and we're painting the baseboards or whatever.
Right.
You're on your knees, you get up.
It gets tougher as I get older, Bus, getting on my knees.
Pay for something to
man.
Pay for something. But in the knee, there is a bursa that lives right across the front of the kneecap called the prepatellar bursa. Put your hand on your knee, move your skin back and forth right across your knee.
I'm doing that right now. I'm feeling it. There's the slippery layer.
That's the bursa. The bursa is allowing that skin to roll back and forth there, very slippery. So I have patients that come in, they got a big water balloon on the front of their knee. It's not in the knee, it's on the top.
So you can see this. It's a swollen water balloon on the knee.
And they bend, and you go, what do you do for a living? Well, I'm a plumber. I've been working on the Joneses' house, and I've been on my knees, and I put my knee down on a rock, or did something like that.
Right.
Or I fell down in the snow. That didn't happen this year, but slipped on the ice and landed on my knee. I didn't tear a ligament, but
it'll swell up.
Fill with fluid.
Bursitis.
Fill with fluid. Same in the elbow. We'll see it in the elbow. Yeah.
And I assume there's not much you do for that other than what do you do? Ice it and take some pressure off it?
There's a lot you can do. You can
what?
Typically, what I would do is if we worry about getting an infection in there, a septic bursitis, which sometimes if you have fallen or a patient's fallen, and they cut the skin a little bit, have a little nick, and then bacteria goes in there and feeds into that source and it gets infected. That requires a surgical debridement.
You got to drain that out, clean it up, get antibiotics in there.
Yeah. If it's just a aseptic one, just someone's on their knees and they have this big bursa, I will put a sleeve over it, compression.
Okay.
You can drain it. We can put a needle and attempt to drain it.
A
lot of times, it will come back because it's a space there that will fill back up. So if we drain it, squirt a little steroid in there, and then put the compression on, allow that tissue to calm back down with some anti-inflammatories, the steroid, and it can then squeeze down and then heal up. But it can be rather difficult sometimes.
Wow.
And if it becomes infected, we have to open up and drain it.
Interesting. Now I want to get into some real nitty gritty now.
Okay, sweet.
The ACL, that means
Okay.
the anterior
Yeah.
cruciate ligament. One of those X ligaments. And tell me if I'm doing this right. If your femur goes back,
Yeah. Actually, if the tibia comes forward,
the tibia goes forward. Okay, fine. All right. Tibia goes forward, that ligament can snap.
Yeah.
And I think is that the most common cruciate ligament? Is that more common
yeah,
than the posterior?
we see a lot more anterior cruciate ligament tears than posterior cruciate ligament tears. So the typical, historically we always thought it was the football player running down the field, gets hit, turns and twists, and it's a contact injury. Really, what we see more is the non-contact twisting injury.
Okay.
I'm a defensive back on the field. You're running. You're the receiver. I'm backpedaling. You cut to make your route, and I stop, turn, and twist, and then I go down.
And that's when it tears. So let's say we have an ACL, it's fully torn.
Yeah.
We have an athlete here, skier, snowboarder,
Yeah,
or whatnot.
For sure.
Another thing, when I was a medical student, I remember someone had an artificial carbon fiber.
It failed.
And it failed. It was splinters of sharp carbon
There
through
was
this poor joint, and they were trying to get it out, and they were just disgusted with this obviously inappropriate material.
There was a time back, probably late 80s, in which they tried to use some sort of silicone or some sort of other source to reconstruct the ligament. So let's go through that a little bit.
Please tell me about ACL and how you.
So the ACL is
evaluate
torn, and the way we evaluate, as I said,
Right here,
and
ACL right here, the front of the tibial plateau to the back of the femur. Okay,
that's great. And so the athlete or the patient comes in, as you said, that we just got through spring break, and there's a lot of folks who are out skiing in whereverville, and they have come in with knee injuries because they crossed their skis.
I'm grateful every time I come back in one piece, Bus. I don't know how many years I got left in me, but
well,
I've
now
still
you know
got
where to
my
come
knee.
if you tear it.
Oh, I know. Another benefit
Come on
for having
over.
orthopedic friends.
Yeah, exactly. And so if it's torn, the patient, when it happens, the knee typically swells. There's blood supply in there. That injury, we talked about energy. So what happens is a lot of times when the as I said, the knee will pivot, and as it pivots, there's this moment here that it ruptures, right? And so what we see is bone bruises on the MRI because there's been such a high amount of energy to cause this injury. And now this is torn, so and there's some capsular injuries at times. So now we have bleeding, right? So the blood that fills up the knee.
So it's going to hurt.
It's going to hurt.
So somebody's going to know if they tore their ACL in half.
Yes.
I'm not talking partial tears. It's all the way gone.
They're going to feel a
Person's
pop.
gonna know.
They're going to feel, I can't walk. If they do get up and walk, they'll feel some instability. Because now when they go to move, that ACL is not there holding the knee in place. And so they're going to feel that.
Okay.
Right? And so they come in, their knee is swollen. They may have some limited motion because it's now stiff. And we do what we call the Lockman test, where I don't know if I can show you.
Sure.
Where we pull the tibia.
You pull it.
Mm-hmm. Yeah.
I had a friend in Michigan, his knee was blown out in the Rose Bowl.
Oh,
and his name was Mike. I'll leave it at Mike. And he would push his tibia out like that.
Yeah, because he could do it, right?
Right, he could do it, right.
A trick knee.
He had a trick knee.
The old trick knee back when we were kids.
Yeah.
And that's the ACL there, right? And so we can assess the stability of the knee based on our examination. And what's nice is when I have my patient, I go to the operative side and they go, ooh, it's pretty loose. I go to the injured side, and then I go to the side that's not injured, and I go examine the knee and go, do you feel this? And a lot of times what they feel, I always do it as this. I kind of feel the end of that.
Then it gets tight.
What I tell patients, the ACL is like a dog leash. Think through this.
Oh, interesting.
I'm with my dog. My dog's here. I got a 3-foot leash, and a squirrel runs out, and my dog also will chase that squirrel down the tree as fast as possible. But if my leash is good and she tries to run up the squirrel, it'll stop. Right?
Okay, it gets to that point.
The check ring. It's
It's checked.
If
Okay.
my dog leash tears, it breaks, my dog has gone ran across the street and
Right.
treated that squirrel.
Right.
Right. So that's what happens. So patients can feel the difference side to side. Oh, you feel that? You feel that endpoint? Boom, boom. It's an endpoint. The leash is intact. I go to the other side. You feel that? I don't feel anything because it's torn.
Because it's torn. So how, Bus, instead of these huge long incisions and using these horrible artificial fibers that don't work, how do you fix these nowadays? What is the state of the art ACL repair?
So if that's torn, and there's some guys, Dr. Smith being one, that can sometimes will do a repair. I haven't quite bought into that quite yet. I think if that ligament is fully torn, it needs to be reconstructed.
Okay.
Reconstructed versus a repair. Repair means I just put it back together. Reconstructed is I use some other source to make a new ligament.
Okay.
So historically, in my career, I've used the what was called the patellar tendon, the bone.
You used to dig out a huge piece of tendon in the middle.
Huge, 10 millimeters.
It looked big to me.
10 millimeters.
When I was a
wide.
medical student, it looked big, and you got these chisels.
Right. So
I would big hunk.
Exactly. I would take
Right.
a bit of the patellar, the kneecap, a 10 millimeter strip of the tissue, and a little bit of bone down here, called a bone, tendon, bone. I would take that out.
Strong.
Yeah, exactly. And now I use a strip of the quadriceps instead of this. I switched to this about 3 years ago.
Interesting.
And really, both are really good techniques.
So it's strong and it's their tissue.
It's their tissue.
It's not going to reject.
That's correct.
Be
Well,
rejected.
and in soft tissue stuff, there's really no rejection of it. Not
Right.
much like heart transplant or kidney. We don't have those antigens on the
It's certainly nobody else's viruses.
That's correct. Well, there you go. Right. Exactly. And
Prions.
if someone's a little bit older, or we can use cadaver tissue. And that then,
so you can get this same tissue from a deceased person donor.
if I tear my ACL tonight, I'm going to use a cadaver. I'm
Okay.
older, and I think I can get back to my recovery faster if I use a cadaver and I don't interrupt my extensor.
And you're not injuring yourself for the harvest.
Yes. But my 16-year-old football player from Rockbridge that tears, I'm going to use their own because one, they're going to recover faster, and there's a high 40% incidence of a re-rupture using cadaver tissue in patients under the age of 25.
40%.
So re-rupture. So if I
Okay.
take someone under the age of 25 and I use the cadaver tissue, I have a high incidence of re-rupture.
And what would it be with their own tissue?
It's less than 10%.
That's 4 times better. That sounds like a good decision then.
Yeah. Now, older folks, I'm not out playing football on the AstroTurf or the artificial turf. I'm going to use a cadaver, and it's a little easier. And so what we do then, once we've taken the graft, we prepare it, we scope the knee, we make these little small incisions, little stab wounds to put the scope in, and I can look around, all around.
Okay.
I remove the ACL, I remove the damaged one.
Okay.
We clean up a little bit of bone, kind of clean everything up, and then we drill tunnels. We have to get that graft up into the bone.
Yeah.
So
How do you? It's got to be anchored.
Correct.
How do you anchor it here?
So if you see the hole right here where the ACL is coming out here, we drill very similar. We drill a tunnel here. I drill a tunnel into the femur, and the little sockets that I can pass suture through the bone, out the skin, and then I just feed the graft up into that socket, into that hole. So the graft goes up into this side, and then I pull the other graft down in here.
How do you attach the suture to the graft? Do you use
we
special
have
knots?
we have special instrumentation that we attach to this piece of, in this case, the quadriceps tendon.
How do you keep it from not tearing through?
It's a good technology.
All right, you have to have special.
It's a special tape
knots,
system that we use, that we wrap it around it. It works very well.
So you can attach that suture, that anchoring suture, to the tendon,
to the graft,
securely,
and then
dependably.
And then we attach it. We drill a tunnel up through the femur, and there's a number of ways to fix the graft. You can use what's called an interference screw. You have the tunnel, the graft goes up in there, and then you put a screw over the top of that.
I've seen that.
It's called an interference screw.
And that's strong enough?
Yeah, it's like this. Here's how I tell patients. You have your sock drawer. and your socks are all in the wash, so you can open up your sock drawer, no problem.
Right.
Then you get you
I
do
know
the
that.
laundry, you
Hey,
take all your socks,
that's
you
how
stuff
it
it in
doesn't
there,
work.
and you
I
have
know.
to push your hand down to shut the drawer real fast,
Right.
and then you can't open it because it's interference. So that's
The sock drawer method. I love it.
that's interference fixation. The other way to fix it is through suspension, where we take the suture, pass it into the bone, and then we have something on the outside of the bone that suspends it, attaches to the bone, and holds it tight there. And that's the
An
technique.
anchor of some sort.
Correct. And that's what I currently use with my quadriceps. Yeah. When I was using bone to bone, I used the interference screw.
Okay.
So we have a number of different techniques to
So it's a secure attachment.
yeah.
How long does it take for that to heal?
So after surgery, after an ACL reconstruction, I keep patients in a brace for about 6 weeks.
Okay.
We start the physical therapy. That's the same day surgery. You come in and go home same day. When you were talking about a long time ago,
Oh,
patients would have the big whack across the knee, have their knee in a cast, stay in the hospital for a week, and then go home with a stiff knee. Now, we send you home within about an hour after the surgery's over.
I'll
feel
be
good now.
darned.
Go home. And the next day, I send you to physical therapy. You go get up, go into therapy, and we start.
And it's gonna bend. They're gonna do range of motion work. Really.
Start working on the knee and get the knee moving again, right?
Listen, there's inherent strength, and once it's anchored in there, I mean,
It's good. Now what I have to do and to wait to get these athletes back on the field or the court or the wrestling mat, you got to let it heal. Your question you just asked me.
Yeah, how's bone and
So,
Lydia's don't have good blood supply? I heard.
It takes about. I come out of the brace in 6 weeks.
Okay.
We don't let the patient go back to full athletic activity. The kind of debate. The debate is 6 to 9 months, somewhere in that area. And what we need to do is allow the body to incorporate the new graft, allow the blood supply to get in there, allow it to heal, allow it to attach to the bone, and then build up the muscles around the knee, right? We want those muscles working again. Once the knee gets injured, the muscles around the knee will shrink up because they get atrophied from disuse and from the
You
injury.
got to keep the muscle strong too.
Yeah.
Because I see not infrequently football player A injures the ACL, and then it's that season. It's a season ending.
For sure. Yeah.
But they come back the next year.
Yeah. I mean,
So you have this down.
what Adrian Peterson did a number of years ago when he tore his ACL and came back the next year and rushed for over 2,000 yards is absolutely phenomenal. But
Wasn't this Josie guy? He also
Well,
came
Dr.
back.
Smith did that surgery.
He did Josie, right?
Yeah, and he had a bad injury. He had a number of things.
He destroyed his knee,
and,
right?
And, Dr. Smith's a great surgeon and got him back on the field and was able to return. And remember that he had that big long touchdown run, and it was like, that is unbelievable. So yeah, kudos to Dr. Smith for. I mean,
Yeah, he did this shoulder.
Yeah.
You got a great group there. So what other? So you can do all that all through the scope now, and it's routine for you.
Yeah.
You can do just another day in the operating room for you.
Yeah.
An ACL.
Yeah, it's
That's
fun. I
fantastic.
enjoy doing it. It makes sense.
So how many hundreds of those have you done, do you think?
I've been in practice 21 years. I used to do a little more. I probably used to do close to 80 or 90 a year. We have more guys doing it in my group, and so my numbers have dropped down. I'm probably doing 40 or 50 a year now, maybe. And so,
Wow. So you may be getting close to 1,000
Oh, yeah, for sure.
for sure. That's fantastic. So what other really cool surgeries,
So I think-
boss,
Are you doing through scopes that 20 years ago was not?
I tell you one area, and we talked earlier about dislocations. I think there are, when the kneecap dislocates, the problem with the patellofemoral joint where the kneecap is, there's a lot of stress that goes through that.
I bet just to think of
standing-
the tons
standing
of
up
pressure.
Standing up from the chair.
Tension.
4 to 5 times body weight. Just
Right.
getting
I
out
mean,
of
if
it.
you're squatting hundreds of pounds, I mean, you've got tons
pressure going through
on there, right?
And so we don't have when that happens, start getting arthritis in there, it kind of breaks down, and it's difficult. Or if you have instability in the kneecap, we have to reconstruct that. One of the ways that we've been doing here recently is we use, much like the ACL, we can use a fake ligament, or not a fake, another tendon sore, or use a hamstring tendon. We can reconstruct the ligament that's not demonstrated on here, but we can reconstruct to keep the kneecap in place. I think that's been a new for young knees that dislocate. We now have another better way now to kind of help stabilize the kneecap. We do
Okay.
that kind of a mix through the scope and through, and then with a small open procedure. Some of the other areas that we're seeing across orthopedics is in the world of arthritis. Can we do some reconstructive?
That's one of the things I
art-
wanted to talk
yeah.
about before I lose you, Bus. How do you resurface this?
Yeah.
I know there's a lot of controversy about what you can do about cartilage.
Exactly, and so when the articular cartilage breaks down, we talked about it earlier about increased friction and that breaking down.
Mm-hmm.
What can we do to that? Well, we can take little dowels from around the knee and put that. You take out a little dowel of tissue with the articular cartilage on it, and just kind of do a mosaic plasty. You just
Like a hair plug.
yes, exactly.
You get a donor site
Mhm.
and you put it up there.
Exactly.
So you can put donor cartilage in there.
We can
I'll be
also
darned.
there's techniques with called ACI where you actually scrape some of the articular cartilage off, send it in, grow up articular cartilage, come back, and then create a little flap and then inject that in there. That can help heal it.
Almost tissue engineering.
Exactly.
I'll be darned.
You can also take, if you have a contained lesion, small contained lesion.
A lesion, for those of you at home, is an anatomical abnormality, a
Yeah.
boo-boo. Something
a boo-boo.
wrong,
A boo-boo.
not supposed to be there. That's what a lesion is.
If we have an injury here of the articular cartilage in the weight-bearing surface, what we can do, we also use cadaver. We talked about cadaver. Someone who's passed and they've donated their parts, we can grab that tissue and then we can put that in there.
Okay.
Much.
Wait a minute. Cadaver cartilage
Yes.
can stay and be durable?
Used in the right way. So if it's
I'll be darned.
if and that's why I said contained. If it's a smaller injury, and we're not relying on the whole thing to heal, we're only hoping to rely on that little area, small area, 10 millimeter area, 12 millimeter, 14 millimeter, not
Okay.
the entirety of that. Then it does.
Patch.
It can heal
And you can do that through the scope.
partway. You're still probably going to want to make a small skin incision, open up the knee to do it in an open to really make sure you have that well seated.
All right, so for that, you need to make a slightly bigger, in my world, be mini lap.
A mini lap.
A mini lap.
Mini arthrotomy in my world.
Mini arthrotomy, there you go.
Yes.
So you can get good cartilage on there. It can stick. It can be durable,
Yeah.
and you can help symptoms. So, is running bad for the knees, Bus?
I think that's a great question.
Because if you don't use it, well, if you wear something down, it's going to wear out, right?
Yeah.
But if you don't use it, you lose it. There's all these different conflicting ideas, and I know with cartilage, if it's you got to keep it springy and hydrated because it makes its own fluid.
Well,
So it's a
joint
it's
does,
a
yeah.
it's a dynamic tissue, so you can't just sit be a couch potato, right?
So is running good? So I'm obviously not built like a runner.
you're a baseball. By the way,
I'm-
Bus was I think shortstop and second baseman
Yeah.
at the University at Kansas State.
Yeah, be careful.
I know.
Kansas
We're
State.
in Missouri.
The
Kansas
good
State.
school in Kansas.
That's right. So you played baseball, which actually is explosive sprinting type motions
Yeah.
to jump around between the bases. So, yeah. So tell me
And so
more.
just so you know, I played 3 years at Kansas State. Walked on, played 3 years. Never lettered, but it was a number of years later I realized that I wasn't the starting pitcher. I wasn't the starting shortstop. I wasn't, I was the starting nerd. Because I got whenever I was a Big 12 or Big 8 at the time. It was a Big 8. I was a Big 8 classroom champion. So when they needed to run one of the athletes out with a high GPA to get an award for baseball, I was that guy. I was the nerd on the team. I didn't have to go to study hall. All the other guys had to go to study hall.
Now,
I did not.
nerd is a compliment nowadays,
Well,
Bus.
of
I don't know if
course.
you're
I'll
keeping
take-
up with it.
My fraternity brothers always called me nerd, so I'll take that. I love
Who became the orthopedic surgeon?
exactly.
Right.
So I was the team nerd, but that's okay. I'll own that. No, but
So what kind of I guess the more broad question is, what kind of activities are good for your knee? Are there activities you should avoid?
I'm in the business. I'm in this business doing sports medicine to take care of athletes, because if you come to me and your desire is to be a runner, your desire is to run a triathlon, the Ironman, and you have something, I'm going to work really hard to get you back what you want to do. Okay. And so I think the question you just asked, what's good for the knee? Well, what are you trying to do? Are you trying to,
So if you
are
love
trying to be
running,
a
you love
biker?
running. Okay.
Yes, okay.
Okay.
If that's your deal, well, let's figure out how to make it so that you can run and still fulfill that aspect of your life that I want to be a runner. Well, let's figure out how to do that. Let's figure out what we can do to make your knees be able to do that. Now, if you're super overweight and you weigh a lot, you're going to have trouble doing that. We're going to have to figure out a way to lose weight.
Okay.
Get the weight off. Really, the knees can wear out. You see a lot of the young females out running and they just run all the time. They're in great shape. They don't weigh a lot. They can run forever.
And they can become infertile when they're underweight.
I
see the other aspect.
There is that.
There's a bunch of downsides.
That's a good point.
Yeah.
But weight, being overweight does cause a problem. And I think there's ways to do that. I ran one of my life stories is I ran the Dopey Challenge.
What is the Dopey Challenge?
Now
Please,
you're
Buzz.
intrigued, right?
I'm very intrigued.
So we're big, huge Disney fans. We go to Disney quite a bit.
Okay.
Disney is home for us. My daughter worked there for a semester.
A cast member.
She was a cast member. It's
Okay.
awesome, right? So proud of her. But we got into doing these Disney runs, run Disneys. You go down, you do half marathons or 5Ks, 10Ks with Disney, and you dress up, and Disney does it
On the grounds, on the Disney grounds?
Yeah.
The races are, okay.
So in 2020, pre-COVID, right before COVID, right, shut the world down. My wife and my youngest daughter and I did the Dopey Challenge. The Dopey Challenge is you run a 5K on Thursday, a 10K on Friday, a half marathon on Saturday, and a full marathon on Sunday.
Oh my God.
Right?
Oh my God, this is a thing.
It's dopey.
That is so dope. I'm exhausted just thinking about it.
And so yes, I did lose. I lost 5 toenails doing it.
Wow.
But what I did,
and you did it.
Yeah, I only did it 3 years ago, and I'm 55. So
You completed that.
Yeah. Now I didn't.
Wow.
I didn't
Hats off, man. Or ears off to you.
we got ears off. What I did then was I ran what's called the run walk method, the Galloway run walk method. So I ran the entire time. I walked the last 8 miles of the marathon on day 4 because it was really hot. People were dropping everywhere around us. It's super hot down in Florida. But so I would run a minute, walk 30 seconds. Run a minute, walk 30 seconds. Whatever the combination. I would set up in the entire run. I would do it that way, which is a great way to do it. Like I said, if I wanted to be a runner, how am I going to do it? I can't go out and run without stopping. I'm just not that.
You found a regimen. You found something that worked for you.
Yeah. So I think if you want to run, if you want to be a biker, in order to protect the knee, biking's really good.
Would you think biking's better than running for your knees?
Yeah, for sure. I believe that.
It's more of a gliding.
Yeah.
And I used to
commute on my bike to work 5 years. About 5 years I commuted, and it was awesome. Now I live in an area that's not safe to bike in at 4:30 in the morning, so I drive, unfortunately.
Right.
But biking's great. I think yoga's great. I think anything for you to work as we age, as we get older, we still need to work on balance. The way to work on balance is to do upright activities, doing some. You don't need to be power lifter. We don't need to be throwing up a bunch of heavy weight. Don't need to be squatting a bunch of stuff.
But some weights with good form.
Yes.
Okay.
Perfect form.
Okay. Right.
And then yoga, I think, is really good. I think doing all that. And I think obviously good nutrition and all the stuff you hear about. But weight is a big thing. As we and I've not done a dopey since, but if I were to go back, I would need to cut some weight and get back down into running shape.
Into running shape.
Mm-hmm.
A question just came to mind, Buzz. I'm going to blindside you with this. Squats.
Yeah.
Everybody loves squats.
Nobody loves squats. Come on, Gil. Nobody loves squats.
Let's say squats are popular. Let's say the pendulum has swung towards squats. This is a constant debate. I want your opinion on it. You're squatting down. You take your knees to 90, or you go all the way ass to the grass.
No,
what is the best form? What's the best knee?
It depends on what lift you're doing, right? There's some Olympic squats where you have to get all the way down. If you're doing it just a squat with a squat rack, you really want to go to 90.
Okay.
If you have any sort of patellofemoral arthritis,
Yeah.
I'm going to advise you not to go to 90.
Even less.
Go 45.
Really?
Because when you get down to that level, you really
Okay.
load in the joint. Now with weight on your back, you
Oh,
So-
and it's
so don't
multiples,
go-
and it's
yeah.
multiples.
don't
We
go
know
down
this.
all the way.
Okay.
I think squats are good. I think body squats are great. I think jump squats are good. I think we do get caught up. You go CrossFit gyms, you go to some of these other gyms, and I'm a competitive guy. You know,
Right.
I'm gonna look at the guy next to me, and I'm gonna go, "Oh, I can outdo him."
Right.
But he may be 30 years younger than I am.
Right.
I don't realize that because in my head I'm 18. Right?
Yeah. Are we all? I think it's a universal truth.
I
Yeah.
don't understand my body, so I'm gonna go do. I'm gonna get hurt. So when CrossFit came out a number of years ago, first hit town, I had a lot of older folks. Not older. I had a bunch of 40-year-olds and 50-year-olds show up at my clinic with overuse injuries in their ankles or their knees or something. And they were, "What are you doing?" "I'm doing CrossFit." Because in CrossFit, it's not like you and I working out together because we're the same age. I'm working out with Hunter, and he's 18, and I'm not, and we're like I'm trying to compete with him.
Yeah,
It doesn't work. You got to be smart, and we get in those gyms and we want to be competitive. Right. We got to be careful, and I love all that stuff. I mean, I love all the different weightlifting stuff around, all the Columbia strength conditioning. I love all the stuff that's going on in town. And I think overall, we're seeing a little uptick on people trying to be healthy. I think we're getting America's really obese right now, right? We're horrible.
We're
absolutely horrible.
But there seems to be a subset of people, particularly in Columbia. I don't know what it is. Every strip mall has a workout place.
Yes.
I just saw some kind of boot camp thing.
Yes.
You can pay a drill sergeant to kick your ass.
Right.
And they've got the jazzercise and the hot works and the spin and the
Have you ever done hot works?
my massage, I go for massages just 2 doors down where I'm going to relax.
I was with
but I did go in there when they were opening to see it.
I went in, we were down with the Missouri wrestling team down in Tulsa at the Big 12 championships the first part of March, and Coach Smith and I, and our athletic trainer, Mitch Swee, we between, after practice on the day before the tournament started, we went to Hot Works, and Hot Works it's rowing, it's biking.
Oh, it's everything. It's got a little torture chamber,
in
a wooden torture
in a
chamber.
sauna.
In a sauna.
And we stepped
everything
in.
You want to do.
The gal flipped it on. It's 125 degrees. I love hot yoga. I love all hot stuff. I'm like, this is really good. It kicked my butt. It was bad.
I'm not putting him down. I think I'm just a little too old for it. It looks like a neat concept.
I love I feel like I'm like going to work out in a microwave, and I should not have to work out for an hour. I can get it done in like 15 minutes. It's a microwave workout.
Oh, I love that. Yeah. I love that. So, Bus, as we wind this down, can you tell me, are there any just miraculous stories, somebody that you thought, gee, that knee is shot. There's no way they're gonna snowboard again.
Yeah.
Okay.
I told you the story about my one patient athlete that did the Ironman.
The Ironman. Any other stories out there where you said, this person doesn't have a shot in hell, but I'm gonna try. I'm gonna put. And then this person came through the other side. They did their rehab. They did all the things they had to do. Yeah. And how can you think of any particular case that was particularly gratifying for you?
I think in my career, I've taken care of a lot of patients, and I'm super blessed that my patients, when they come to see me, I'm going to motivate you to. I'll do my job, you do your job. In fact, I have the easy job. I mean, what I do is rather easy. That's easy to do. You have the hard job as a patient because you have to work through all the rehab.
Yeah, you got to do the work.
And so I think a lot of my patients have that ability. I've taken care of multi-ligament injuries. I got athletes from all around that have gone through surgery. I've got recently just took care of a guy that was at some of these semi-pro football leagues. He was an older guy trying to still stay young and play, and he blew out his knee, and we worked on him. And look, in those guys, I want to get you back on the field, but you also have to go back to work because you're raising you're married, you're raising your kids.
Yeah.
So I think nothing jumps out of my head of it, but just as I think through my career and all those patients that come in, and I'm humbled that they would allow me to take care of him and take him through this horrible injury.
Right.
And I see myself as not only the physician doing the work, the surgeon doing the work. I'm right alongside you working through it. And I think patients can get good outcomes if they spend the energy and the effort, I mean, to do it. We can get patients through these big, I mean, there's a lot that can go on. We talked about this.
Sure.
A ton of stuff that can go on in the knee. It takes hard work, diligence, and an attitude to get up and do the exercise and the rehab to do it. I think that what's hard is when you have young athletes. I mean, I don't have to. I'm fortunate. I have in my career. I've had the patient where you look at the X-ray and there's cancer.
Oh, that. Yeah.
But I'm a sports guy. I don't. I have that story in my background, and I have a gal that did show up one time and had a big, came in with her knee hurt and had been seen by a physician in Kansas City. I'm not sure what they were doing, but she showed up. I got an X-ray and she had
bone cancer,
osteosarcoma. And I remember going, holy crap.
Yeah.
And I looked and I was behind in my schedule. I'm like, I need to spend some time in here. And went in and talked her through it. And big tumor, young gal. I called over to St. Louis at the time where I send my bone tumors and stuff and talked to the guy there. She was from Jeff City, just moved back from the Kansas City area. Her parents lived in Jeff City. She called her parents in Jeff City. And we got her over to St. Louis that day to see the oncologist, the tumor doc.
You made a call. You made it happen. You opened the door.
And I tell the story. And
please.
She, several years later, after that, I've seen her back as a patient, and she's doing great. So we
saved the limb.
Saved the limb. She had big surgery, saved the limb. But I have on my desk, in my place where I have different things on my desk at the office, I have a letter from her thanking me for taking care of her. Right. So when the world is upside down and craziness happened, and healthcare has gotten much harder now than it used to be. It's just the nature of healthcare.
Right.
When those days happen, I get to go up and pull out the letter. I pull that letter out quite a bit, and I go, okay, I'm doing the right thing. I'm here for the patient. I'm here to help. And thank you for thanking me, because it does, those long hours, those many nights that you think about it, and you have those same stories.
Yeah, I have about 6,000 pictures on my wall that tell me the same thing.
Yeah, and we get the opportunity. Healthcare is awesome. I would never turn anyone away from healthcare. Both my daughters are in healthcare. And I've never turned away, because we have the opportunity to come along people when they're down and in a bad place and help them along and get them through that. Now, I don't have to take care of tumor patients. Like I said, I have the job sometimes of telling a 16-year-old athlete from the high school, your season's over, you tore your ACL.
Yeah.
It's your senior season. You never play football.
There goes the scholarship. Yeah, right.
And so I had a kid one time, a young kid, I think he was down near the lake area. I think he was one of the, maybe Camden or Summer. Came in, he had torn his ACL. I went, you tore your ACL. And I walked back in. I go, buddy, you tore your ACL. We're going to have to fix this. And he got super upset with me. Stormed out of the room. And his parents sat there and aghast. Like, they were so embarrassed that he would do that. I said, don't worry. We'll figure it out. It's okay. I understand. I played ball.
I was 16 once. Yeah. Good for you.
I appreciate his passion. I love it. And so he stormed out of the room, and they came back a week or two later. We fixed him, and he ultimately went to Missouri Valley College and played college ball. And I just remember that kid, and I made fun of him. And I've since seen him for another issue, and I go, you remember that day you stormed out of my clinic? Yeah, So, yeah.
And you're all best buddies now.
And now we're all best buddies, right?
That's fantastic. Well, Bus, what I have learned so much here. This has been a very, very special conversation. It really is an honor and a privilege being a physician, having people trust us to improve their lives, turn their lives around. I've had a wonderful time learning about the knee. I know you can put telescopes in other joints.
Yes.
So maybe in a future time, will you come back and we can talk about other injuries to other joints in the body that an orthopedic surgeon like you can fix?
I would love to. Thank you so much.
What a pleasure chatting with you, Bus. Have a great day.
Yes, thank you.